So I just want to thank you both so much for being here. I don't think I have to be terribly formal, but this is Paul Garza, who is the chair of the Mendocino Coast Healthcare District. And this is Serrahn, Dr. Robin Serrahn, who is the chief of staff, medical staff at the hospital, and also our new hospice doctor. And I'm just really grateful to you for coming and telling us what's going on.
Yeah.
I thought there might be people out the front door, but we'll pass the word on.
That's fine. I like small. I'm used to one person at a time. So.
Oh, being a doctor, that would make some sense.
Yeah. So why don't you start, Paul?
Okay, well, clearly a lot is going on right now, and it's regrettably been misrepresented in the press pretty badly. Adventists decided that they needed to request a 60-day period to renegotiate the agreement that we have standing. And of course, we didn't. That's just part of that was part of the lease agreement to do that. So we went into it. We've gone into negotiations. We've had 4 sessions so far. We have 1 more scheduled. It's unlikely that there's going to be any change to the conditions of the lease. So if there is, it's going to be a little bit of here or there, and that's about it. Fundamentally, the idea isn't going to change. I don't. Although it's possible at some time in the future that Adventists may decide to depart this community, I don't see that happening in the near term at all. They've made a pretty substantial investment, if you think about it, in terms of personnel and recruiting these guys. I mean, they were very fortunate he was there already. Recruiting these guys is very expensive business. So that's one indication. There's been a lot of concern about service lines at the hospital, and there was a rumor floating that they were on the verge of getting rid of oncology services, but that's not happening. There was a consideration of it. I'd say that's fair, but fortunately, Dr. Miller and others went to work and showed them how that actually is a profitable center for them, and so that has been turned around. That isn't going to happen. Looks like we're headed for an agreement, and these are all side agreements, that once a year we're going to sit down together and look at service lines at the hospital, and that kind of a process will be really healthy and clear the air, I think, for a whole lot of things. As I see it, Adventist problems in this community stem from partially things that aren't their fault. I think the hospital went through a tough time and developed a bad reputation, or at least a mixed reputation in the community, and they inherited that. I would say that they probably had not done a very good job of engaging in the community to change that perception, and it's something that I really want our board to become very active in the next year. One of the major problems that the hospital is always going to face, and by the way, I always like to ask the question, who owns the hospital?
We do.
Yeah, raise your hand. We
all do.
own the hospital. Well, one of the big things that we have to confront is this perception, and the hospital, 78% of the patients who are served at the hospital receive Medicare and Medi-Cal reimbursement. And those reimbursements do not meet typically the costs, right? So the rest of it is private. It's very small. That makes it hard. The people in the Mendocino community, I think of as Casper and South, are the people who are most upset with the hospital and complain the most about it. They're also the people with the most income and most likely to have private insurance. And those are the ones that we're losing. We have to capture those people. We have to change the perception of the hospital. What I'd like people to look at the hospital and say, okay, it may not have everything that I could have, and as I like to describe it, the only time I've experienced a hospital that I think had every possible service that was high quality that you point to, the only hospital I've ever seen like that is Cedars-Sinai, and we're never going to be a Cedars, right? Okay, but the hospital if we look at a very important measurement, patient satisfaction, at the time that Adventist took over, the patient satisfaction was a little above 50%. It's now well over 70%. That means that people like Robin have worked really hard and made a difference, and the quality of care has gone up. So I think that's something that hasn't gone out to the community. That's unfortunate. Part of what I want to do in this engagement is that we need to do a strategic plan. The big problem that we're dealing with is, where do we go from here? The facility's aging. Current facility is going to require $39 million of today's dollars of maintenance between now and 2025. All right, that's a lot.
Is that independent of earthquake?
Pardon?
Is that independent of earthquake?
Yeah. About $17.5 million would be a seismic retrofit. The rest is just things that need to be done. It's an old facility. We have to create a more modern facility. We're going to have to do something to add to it, build it out a little bit, repurpose some of the buildings. It's a complex process. But what I want to do is launch, as a result of this, as a really serious strategic planning process. And so what I would like to see us do, and I can't promise we will, because I'm going to need the consent of the other board members, but what I would like to start is probably at the end of January, coming in and doing, acting as if we were working like a legislature, which I think is appropriate for us, because we are a government agency. I'd like to host maybe a 3 or 4 hour workshop where we get the data that we've gotten from the California Center for Rural Policy on health. And I don't know if you were ever exposed to that, but it's a brilliant study. It really showed us a whole lot of things that were important. I'd like to get all of the data that Adventist has and like them to present it. We're hiring a consulting firm that's going to do a full market study of our community, and then we're going to get a lot of information about utilization, not just from Medi-Cal and Medicare, hopefully from everything. I've been told by one of the state agencies that I can get all payer data, quote unquote. So hopefully that comes through. And then get people like Mendocino Coast Clinic come up and report, but not just come up to say, okay, we're doing a great job. I want data. We want data, right? I want data from the sheriff. I want data from the police department. I want every place that we can get. Bring that data and let's talk about this, and then have people in the community chat. And then I'd like to organize a group of subcommittees that are focused on some of the issues that emerge from that would be full of community participation. We'd have some board members there, but most of it would be community. And get to work on these things, really engage our community in planning the hospital that's going to be here and for the future. And I believe that kind of process is going to give us the best result in terms of what we need to do with that hospital, with that facility. And it's also going to increase awareness of what's going on, and it's going to bring people to a sense of ownership. It is your hospital. You should be vocal. But we have to create a mechanism for that. It's the hospital is so important, obviously from the point of healthcare. I mean, you can't belabor that point. But the other thing that when we were talking about the bond, I spoke to a few of my friends in Fort Bragg who are business people about it, and I said to them, look, the hospital produces an economic development input of about $120 million a year. You take that out, hospital closes, you take that out. What's your business going to do? And they go, oh my God, yeah. I mean, most of the living wage jobs in our community, most of them are at the hospital. Now, you could point to a few other places, the city and the school district. What?
That's not a living
Safeway.
wage.
Safe, yeah. A few others.
It's union.
There aren't many, right? And those, and so it's vital. So it's very, very important. I feel privileged to do this work, as difficult as it has been at times, because we inherited a mess. When I came on the board, we had 25 bank accounts.
You had 25 what?
Bank accounts? You talk about a perfect environment for embezzlement. It couldn't have been more ideal. And God knows if it happened or not. We'd have to take a forensic. I don't want to speculate on that. we'd have to get a forensic audit to determine that. But the point is, it was ridiculous. Well, we're down to 3, and we're probably going to have a 4th account. That's it. One is just an investment account, one's an operational account. The third is our Measure C money. There was a request that we isolate that into a separate account. And we got some push on that. Said, okay, fine, we can do that. So, so that's kind of where we are. So fiscally, we're much stronger than we've been. We've got a very competent CFO. I don't know how many of you know Kathy Wiley, but she's our district manager. She's really very, very talented woman, and she's done great work. We've got Wayne Allen, who formerly was the CEO of the hospital. He's from Sparks, Nevada. He phones in, but he's working very hard at us, and we have changed. The other thing that we've changed is the year first part of the time I was on the board. That year we spent almost $40,000 on banking fees. We had all these accounts. No one had any understanding of what was going on. We're paying banking fees everywhere now. We have a substantial amount of money that we're sitting on. We shouldn't be paying banking fees. Banks should be standing up, trying to get our business, right? But it was the incompetency of the former folks. I'm sorry, it was just kind of shocking. We got rid of, so now instead of paying banking fees every month, because of the investment policies, we're earning about 35 to 45, depending on how the T-bills do, 35 to 45,000 additional dollars every month from that money. So there's a lot that's changed. So I hope this is good news to all of you. We're trying this really well. So I can tell you from the administrative side, that's kind of what's going on. And I can tell you that I believe that we're going to get through this period with Adventist, and there's not going to be anything significant that's going to change. And so I think we'll be just fine. What I think the board's business now going forward is to really build a much better relationship with the community. And if we do that, I think we'll achieve success. Probably we're going to have to go out to you at some point in the future. I don't see it. It may not be next cycle, but at some point to get some more money, because the money that we have is going to get hit by inflation, and so we're going to need some more.
The retrofit. Yeah, that's what you're talking about.
Yeah. The retrofit we can afford, but it's everything else that we're going to need to do. That's going to be. We have more than enough money to do the retrofit.
What's the date on that? When does it have to be done?
Well, the legislature just passed a law, and it's now 2033.
Okay, I know it keeps getting pushed.
Yeah, and then we also, if we're financially distressed, if we qualify for that, it could be another 2 years beyond that, and then there's some additional funding that the state is going to provide. So we're looking forward to putting all of this money together. But so that's a big thing to accomplish, and so that's where our focus is going to be. And now let me have Robin tell you about all the things that will be done with medicine.
Well, let's let this be very informal. If there's any questions, just interrupt us and we'll...
Yeah, please.
I'm curious as to why Adventist asked for this period of time. I don't know whether to call it a renegotiation or an evaluation or whatever.
Oh, that's a good question.
Can I answer that?
Okay, go ahead.
I was going to say something about that. What's the backstory? In this country, I understand between 50 and 60% of hospitals are losing money. Okay.
It's a for-profit system.
There's a few problems, yes. And our hospital has been losing money during the 4 years with Adventist Health. The Adventist Health system has lost money 2 years in a row. So they're anxious. They can't keep doing this.
System broadly? Or
Broadly.
Just here? Broadly.
Broadly.
Just not here.
Broadly.
Okay.
So when I speak about Adventist Health, I'm going to talk about like the 22 hospitals on the West Coast in Hawaii. That system has lost money 2 years in a row. So they need to stop that. And so they wanted to look at everything. And so they gave us this request to renegotiate. Part of that was that they wanted to capture certain monies. And there's something called intergovernmental transfer. Now, healthcare economics is unlike any other economics, okay? You don't get that in Economics 101. But there is a way for Medicare monies and Medi-Cal monies, which is Medicaid, but Medi-Cal in California, to backfill the costs of the care, which they don't pay for. So in other words, if you go to the store and a gallon of milk is $4, the government will come in and say, well, I'm going to give you $3, and you have to give it to me. It's kind of crazy, but that's how it works. They tell you what they're going to pay, not what it costs. So there's this other mechanism called an intergovernmental transfer. And if they rearrange things with the district, they could get some more Medicare monies. The reason I'm going into this in detail is there's a point to it. So bear with me. They found out that wasn't going to work for Medicare because then we would have to lose our license for our electronic medical record system. And when you buy it as a group, as a system, it's one price. But if you buy it individually, it's a whole different price. It's like individual health insurance. I have a colleague in the ER who is perfectly healthy, probably late 40s, no issues, and she's paying $1,700 a month for health insurance. So individually, you pay a lot more. So after they gave us that notice, they found out they can't do that because it would cost too much for the Cerner system. But what that says to me is that they're committed to our hospital because they want us to continue, and we're going to continue to have Cerner and later go on to this other system called Epic. Now, what they can do is with the Medi-Cal money, they can do this thing called an intergovernmental transfer, which is goofy. It's like we give them $1, they give us $2 back. That's what I mean by goofy. But it's another funding mechanism to fund the hospital.
So let me just, if I can add to that, they initially approached us, and this wasn't part of this is before the negotiation, so I can talk about this. They approached us and they thought they had a plan that would give us $15 million more every year. Well, okay, what's the plan? It'd be great. We got $15 million and solve a lot of problems. But we looked at and then they talked to us about it, and we said, no, that doesn't make any sense because the intergovernment transfer is based upon your tax base, right? So the tax base, we get $1.6 million a year for all you taxpayers. That's it. Mm-hmm. Okay. So we could get through intergovernment transfer about $1.2 million additional dollars, and we're pursuing that now. Very famously, the former treasurer sent $1 million into that intergovernment transfer, and the state denied it, and it took us forever to get the money out. Well, the person at the state, we found out, made a mistake, and they should have been allowed. So we think we can get back into the 2024 pool, which would give us another $1 million, and then going forward be able to get that $1 million, which would make a difference. It's not a lot, but that's all you can get because, again, it's based. I don't know where Advantage came up with this idea of the $15 million.
Well, when they did further research, they found it wasn't going to work. And what they told us, at least, was it was also the Cerner, and then they did the pluses and minuses, and it turned out to be a minus.
Yeah. The one thing that they are proposing that I think would be very good, and I've already testified to the board of supervisors in support of, and we'll continue, at least personally, to support that. Hopefully the board will, is a business improvement district. This is Ted Williams' idea, and Ted always comes up with really interesting things. I'm very fond of him. But the idea is that Adventist would apply an 8% tax onto every billing that they do for Medi-Cal, Medicare, and private insurance. And so they would, just like the typical model for a business improvement district is you have an area of your town, like there's one in Fort Bragg, okay, that needs some redevelopment. And so the owners of the businesses and property owners will get together and they tax themselves, right? And then they use that to make the improvements that are necessary. And there are lots of examples of this being just transformative. It's really wonderful. Well, what they do is kind of like a big one, countywide, a business improvement district. All the hospitals would enable that. That could produce, they believe, maybe as much as $40 million a year.
Wow.
Now that would be
matched with this intergovernmental transfer, or just
no. Well, they would still.
without that?
They still have to use the intergovernment transfer because they collect the tax that goes to the state, and then when the state returns it. Why, I don't know. I mean, sometimes you think this is a little bit crazy, but that's kind of where we are in government. But that's pretty good. Now, the people who are getting served don't pay that. That's a tax on the payers only. All right, so it wouldn't mean that you would have to pay more for your services at the hospital. That 8%, that would just be it would So
Is
that would
paid
be a
by
good
the
thing.
insurers?
Pardon?
Paid by the insurers?
Yeah, that would be the tax. That's the idea. I have talked to our attorney, who happens to have some expertise in these kinds of things. He believes that Medicare and private insurers would pay that. He's less sanguine about Medi-Cal, but maybe they would, but he's not sure. In any case, this would produce some additional revenue that would be helpful. As I understand it, Willits is struggling a bit as well. You know, the Howard Memorial, it's a nice facility. It's new. It's much nicer than ours. But they're also struggling. I don't know how Ukiah is doing. I haven't looked at any numbers there, but so there's a reason for all of this, and it would be really, I think, a really positive thing to do. Anyway, we'll see if that happens.
Rebecca?
Thank you. That's okay. I think that some of the granular aspects are maybe too granular for me to interrogate, but so I was just wondering if I guess these three things out of what you guys are saying. So partially the renegotiation was to redo the agreement so that the intergovernmental transfer could happen, even though how that's gonna look is still up in the air, because before the agreement between the board and the Adventist didn't allow for that anyway. Is that correct, or is that rumor?
The reason for the intergovernmental, the reason for the restructure was that because it would require, to get this additional money, it would require the district then again to be the recipient, the biller and the recipient.
Rather than an Adventist. Okay.
Yeah, and
Because Adventist Health is not a governmental agency.
Right, okay.
that's
So
why.
you have to take a different role.
Yeah, and I looked at that and I said, okay, well, if it's $15 million, I guess we could do that. But frankly, I was very reluctant to go that way because I think that we should just manage the taxpayers' dollars. That's my own view of what we should be doing at the board. I don't think the board has the expertise to run the hospital now. In the old days, the board was really different. I remember when I first got up here, you have people like Dr. Glusker and other folks like that who seemed to have a good sense of business as well as practice. I don't know. You probably could remember many of the board members. Anyway, they were in a position, I think, to do a better job. I'm not. I don't know. I'm not a medical person, right? I came to this economic development. We have a nurse now joining the board, but the rest of us are just trying to do good things. And frankly, some of the people in the past who have been elected to that board are really frightening. And so do you really want that board to be running the hospital knowing that you could get crazies?
Well, so that's part of my second question. The 8% tax, or that example that you gave, so that's not levied on purchases within the community. You said it's to the insurance, because I do think part of why I'm at this meeting and part of why I've been curious about all of this is because I feel like as I work at the hospital, I spoke with you on the phone, and I know that that a lot of people are coming to me for information because there's just a history of trauma with the board, essentially.
Oh, yeah.
And I want to have a sense of what's going on so that I can speak to it better and be an ambassador for the hospital, because I really do think it's a kind of, there's potential for a win-win situation here, and I do feel like everyone's aiming for that. That said, yeah, the history of the board is just unbelievable. And so if part of what you're saying is, intergovernmental transfer status aside, that we might work just with managing our taxpayer dollars differently and also managing the finances differently. Those all sound like really good starts. what's the like strategy for making the community give more tax money if it comes to that, so that, how are they gonna trust the board? I'm worried about any more measures passing or any more taxes. I think it's a good idea, but I feel like it's gonna be a huge campaign to get people to give more money.
Well, the polling that we had was pretty encouraging when we thought we needed to do the bond. Now, the idea for the bond was based upon, again, that crazy financial situation that when I came on the board, I inherited. It was, I could understand it. Once we got it straightened out, we found out that we had more than enough money to do the seismic retrofit, and we could project between now and 2030 we would get $41 million in, and maybe even better, because of if with good sound investments we could perhaps increase that. And so that was pretty encouraging. So at the point that we saw that, we said, okay, fine, no point in going for the bond. How can we go out and ask people for more money when we're sitting on enough to do the job, right? But I don't know what it's going to. I don't know what the situation is going to be in the future. One of the kind of issues is that the ambulance service, which is essential for all of us, and it's also essential for the hospital. We the hospital would really hurt without that ambulance service, as well as the community. But a typical ambulance run is costs $4,000, and Medicare reimburses $1,200. So we may end up, that's very, very in the near future, asking for maybe $50 or $75 on your tax bill to keep for the hospital service. I'm not saying we will, but that's a possibility. It's something that we need to think about. And you're right, it's going to be very hard to go out to the community. We're going to go into, I'm convinced, and this is just my own point of view, it's not a point of view of the board, so we want to differentiate here. I'm convinced we're in for a really hard time economically in the next few years. People are going to be reluctant to want to be taxed themselves, you're absolutely right. So without this quality of engagement, without people having a real sense of ownership, as long as they keep thinking, Adventist Health are those guys out there, they're doing it. It's not mine. I know one of the things I run into all the time, people think Adventist owns the hospital. No, you own it.
Can you say what that
can I
means?
just say, as someone like brand new to all this, like I know none of the history, you say you own it. Can you just explain how do we own it, and can you also explain how do we, what is that, and also, maybe I should already know this, but I don't. Can you just say a little bit about the board? Like, who is the board, and what is the
Okay,
board?
may I take that?
Yeah, go ahead, please, yeah.
So I want to speak a little bit to Rebecca's point too. We have had issues on the board. We all know that. And I think what's really important, and what I really want to emphasize when I hear Paul Garza say, essentially, we as a community don't have the expertise to run a hospital. We don't, okay? But we own the hospital. So what happened with Adventist Health, it was a lease. They would lease the hospital and manage the hospital, which is a good thing. Because again, we don't have the expertise. Doctors don't have the expertise. RNs don't have the expertise. We just need to be humble about that. But we still own the physical structure.
And we means who?
The district,
The district.
which is us. All of us.
By paying
You know.
taxes.
But it's a
By
bigger
paying taxes.
district than Fort
Yeah.
Bragg.
Oh yeah, it goes all the way down to, well, not quite to,
Our service area extends from the county border above Westport down to Elk. Now sometimes you'll see a map that says a secondary area, but we don't tax that secondary area. I don't understand even why that secondary is mentioned. That's everything south of Elk that goes down to Wallala and all of that. But people down there, they go into Sonoma County for medical services.
and they come to us too.
They do
really?
come to us.
Oh yeah,
quite
absolutely,
frequently, yeah,
absolutely.
for whatever reason.
And
Okay.
the other thing about trust, which is really important, I'm feeling really very positive about our current board starting January 1st. I think it's going to be the best board we've ever had. I mean, to hear that kind of admission that we don't have the expertise to run the medical aspect of a hospital, it to me is so reassuring.
We
So-
hope you can run the business aspect.
Well, I don't even think we do a good job there as well, because it's very complex and you have to know a whole lot. But I think we can manage your taxes effectively.
Right.
Because you've made it, we have a charter. The charter says this is what the taxes are for. We've got the Measure C, this is
Right.
what that money's for. And we just need to execute on that and do the best job we can about handling your money in a way that it grows rather than diminishes.
Yeah.
Yeah, I mean, that's,
$40,000.
that I think we can do. And I think we can also, engage the community. One of the problems is that Adventist is always going to have is they're a big corporation, or they're perceived that way. They're actually a nonprofit. And I have talked to a lot of people, and their reputation is really good. And now that's not to say everything that happens at the hospital is wonderful, but I say as an organization, they have a really good reputation. So that's an asset for us as well. But they're still always going to be perceived as the big guy, especially in this community. We don't like big guys. We want to level the playing field somehow, and I don't know sometime. But anyway, and there's always us against them kind of attitude. I think that people develop, which is really unfortunate. But the board are your representatives. We work for you. And so we're the ones that have to have an important voice in this, because, like I say, we're on your side. Now, you may not always like everything that we do, but that's what we're trying to do. And I hear, Adventist this, Adventist that, they're going to do it. My God.
It would just help if Adventist would answer the fucking phone.
Well,
I would agree with you. Okay? I would agree.
I always answer the phone if I'm walking by and it rings.
Well,
Station 2.
I have had that same issue. And let me just say, it's a work in progress. And the
Yeah.
progress has not been very good.
Well, it's gotten a little better since COVID.
Well, it needs.
I know, I just mean, when you call any department, a whole lot of times you get, an automatic, we're busy right now, we'll get back to you, you leave a message,
Yeah.
nobody ever gets back to you.
Understandable. And when I'm in the ER, I need a patient. If I used to work in the ER, I'm not retired from the ER, but patient needs follow up. If I call Mendocino Coast Clinic, somebody actually answers the phone. Oh, I love it. I call our health center, like someone needs a podiatry appointment or something like that. I have to listen. If this is an emergency, call 911 3 or 4 times.
And then they put you on hold and you have to
Okay.
listen to
So-
the corporate message and music.
Bad music too. So anyway, I can say that I hear that, I've suffered that, and that's got to get fixed. And there are some plans, but we haven't got it fixed yet. But
But I mean, that's kind of where the Adventist rubber meets the road.
it does in terms of meeting the community.
Yeah.
What Paul was saying about, I agree. So
that influences public perception, and if I were to be critical of Adventist, I guess I have a right to say something a little bit. I don't, and given that all the positives that they have, and hopefully I've been very frank about that. There is a lot of positive here, but they don't seem to understand that this is a very small community, and rumors are very powerful, and the kind of public relations they like to do is well suited for an urban area and not suited for this kind of environment. And so we would like to help them reach the point where they understand that better. And hopefully we'll make some progress. But you're right. I mean, it's simple things. My own daughter, she during the last winter, during the really intense rainstorms, she had a new dog, and she took the dog out on a walk, and the dog bolted, just in her driveway. She fell and she broke her wrist, and for her that's pretty catastrophic. It was her right hand, and she's a graphic artist. That's her business. So so they went to the emergency room. They did a good job of dealing with her, but they told her that they could set it, but they weren't they didn't believe that they could get it back exactly, the way it was before. They could get it their estimate was they could get about 90% of it done. Okay, fine. You don't expect orthopedic surgeons in the ER. I mean, that would be, I think, beyond reasonable. And so they made a referral for her to go to Willits. Okay. Well, and so she was expecting a call the next morning to go to Willits and be immediately dealt with, and the call didn't come. So about 11 o'clock, she ate something to eat. And then she got a call at 11:30, and they said, "How come you're not here? We're expecting you to come in." Well, the nurse apparently, got the referral, but she didn't bother to. They didn't talk to each other, so she didn't know she was supposed to be there. It wasn't a terrible thing. It was a week of suffering for her because they were able to schedule it the next week. But that kind of thing, people are very unforgiving about.
Sure.
And I understand it. When I went into the emergency room, I got one of these really strange things where when we were moving in, I fell and hit a redwood thing, and I thought I just had a bad scratch, and I cleaned it up pretty well. And I was wearing jeans, so I thought it was fine. All of a sudden, I developed this really big infection underneath the skin. Fortunately, he was there to fix it for me. And I remember him cutting me open and going, "Wow, that's amazing." I said, "Where did all that stuff come from?" We had a great conversation about all the stuff that was coming out of my leg. He said, "I haven't seen one of these since I was dealing with addicts, heroin addicts in San Francisco." And I said, "Well, I'm not one."
So
yeah.
I want to say something good about it, Dennis, just to back it up. And this speaks to Rebecca and our inpatient team. Currently, our statistics, which Medicare looks at, if you look at our mortality at our hospital inpatient and our safety, we are the top hospital of all 22 Adventist hospitals in the West.
Wow.
I didn't even know that I'm the nurse lead on the floor.
Well, no,
That's great.
we got to get the good news out.
And I want to speak to it also not because I'm trying to, Pollyanna over or anything,
Mm-hmm.
but because that whole us versus them mentality that I really understand and admire the spirit of our community and think that it got us through decades of an underfunded local hospital that can spit and glue kind of mentality worked, and it's taken a while to meld that with having the resources of a corporation and the style of a corporation.
Mm-hmm.
And even in the process of my being there through that transition and COVID and taking on a different role at the hospital, because I both work bedside nursing, patient care, and I have a leadership position, so I kind of straddle these things. I've had an us versus them. I remember one time talking to the patient care executive who I have a lot of dealings with, and I actually said to her, I said, "Well, when you guys do this," and I was like, "Oh my gosh, I'm talking about Adventists, but here I am, the you guys is me." And I just caught myself saying it, and I've noticed that shifting internally over, I both, notice our clinical, you spoke directly with figures, but I think our clinical record right now is really good. I feel our
Mm-hmm.
clinical strength and our clinical focus has become really, really, I see it improving all the time. And I see us responding to mistakes and gaps with more laser focus. And to me, that's pretty much the most important thing inside the hospital. And then I also see that Adventist is learning us. The whole idea that they're a corporation and I do think some of it might, dealing from the outside, trying to get my parents' care, with the clinics, I'm like, oh my God, yeah, you guys need to answer your phone, not send any more of these colored flyers, or you're gonna make my dad go completely nuts, basically, rather than 80% or whatever. So I've seen it from both sides, but I really do think that the longer they're here, and I see the commitment of a larger organization to us, or the people that are here as part of that larger organization, And they're learning our style, and they're learning, like, I do feel like it's a developing relationship, and we're doing that thing where you like are laying all your cards on the table and learning about each other and having healthy conflict and learning from it, and I feel like it's an evolving relationship. So I do feel that, like with the board, there's a lot of evolving going on, and it's moving in a positive direction in addition to these with these clinical aspects. So I do want to add that positivity, because I feel like it's important as we try to figure out what to invest in and what to trust
Mm-hmm.
and what to pursue.
That's good to hear.
Yeah.
Mm-hmm. Yes, Mark.
I have a couple kind of just questions, I guess, about how parts of things work. And one of them is about specialty care.
Mm-hmm.
And I know that lots of us travel to other places to
Mhm.
get specialty care. And so I have two questions there. And one of them is, every time that we do that, are we sucking some money from the local hospital world if we go out of the Adventist system or something like that? And then the related question is there likely to be more telehealth and that sort of thing to bring more specialty care here? So that's one set of questions.
Okay, let's start with that.
Start with that.
The answer
I
to
have
the first
another one.
question, short answer is yes.
Mm.
It sucks money.
Uh-huh.
And Adventist Health is very much aware of that, is how much health care goes out of county.
Mhm.
And they have a commitment to keep health care local. Now, we're not going to do cardiovascular surgery here on the coast. You know, it's never going to happen, nor should it,
No,
okay?
but a cardiologist would be.
Well, actually, yeah.
More than once a month.
Yeah.
Yes, it's a slow process. We're trying to get more specialists to come here, like Dr. LaMonica, the urologist, comes, I don't know, once or twice a month or something. She's actually going to do surgery here. There is a cardiologist coming. We're trying to get more of that.
Mm-hmm.
The second part was the telehealth, which I guess it's funny to say it's a gift of COVID, but you know, COVID has really changed the whole telecommunication, and we're doing more and more of that. You know, for example, like if someone needs a doctor or needs some sort of follow-up, I can talk to Dr. Shah Khan, email him, and he'll follow up the next day. And he's seeing that, and I've heard a lot of good positive comments from the community about that. So we are going to see more of that. Can't replace everything, but I think it could be a major part, and appears to be.
And we have a teleneurologist starting this week.
Yeah, teleneurologist, yes.
Wow.
We have telenephrology.
Wow.
So these are the kind of things you don't always see from the patient perspective, but we're trying to build up a structure of that so we can keep care local.
So my other line
And
of
let me,
questioning.
before you
Okay.
go on to the next one, let me just add, one of the things that we want to make sure we do as we design whatever this facility becomes is it's going to facilitate that telemedicine rather than be an obstacle to it. The current structure doesn't help us. It needs to, so that's that's another part of the puzzle. But anyway, go ahead.
Yeah, no, well,
Yeah.
the second,
My second line of questions has to do with Adventist being a religious organization, and this
Yes.
may be the rumor mill
Mhm.
also, but I'm curious about reproductive health, and I'm curious about end of life, aid in dying, and I'm curious about gender affirming care and some of those kinds of things,
Right.
and sort of where they fit in the matrix
right.
with Adventist.
So that's a very good question. It's a fair question. It's a delicate question. I first, after residency, worked at St. Anthony Free Medical Clinic, which was a Franciscan organization. I didn't run up a red flag and go like this, but I gave birth control, okay? And it was like kind of a don't ask, don't tell. So you got to pick your fights, okay? So I'm trying to be obtuse, but yet answer your question.
So if Adventist has all the hospitals in the county, where can you get a medical abortion, for example?
You're not going to get a surgical abortion.
Yeah,
I
I guess that's the way.
Anywhere?
No, you're not going to get an elective surgical abortion.
Under
No.
Adventist.
Yeah. Now, if there's, we've seen a lot of this in the United States where a woman's having bleeding during her pregnancy, and doctors are afraid to terminate, which happens to be something medical. And now some doctors, I guess, in certain states are reluctant to do that, and there have been problems. We all know about that. I don't think that's happening here.
No, but I'm
Okay.
curious about Adventists' role in that area.
Again, there aren't going to be elective surgical abortions in the county. There are ways to get misoprostol, the medical abortion. There are. But I'm not trying to raise a red flag here.
Okay, good.
Okay?
Yeah.
All right?
Uh-huh.
Is that fair? I'm not trying to not answer your question.
Right. Actually, okay, so I have no dogs in the fight or whatever.
Okay.
I'm curious, both of you have been very careful not to say some things,
Yes.
I think, and I'm curious what your roles are with regard to Adventist. But I also want to hear about medical aid and dying. And
Yes. Okay. So let's get to that. You know, since I am the
gender-affirming
hospice.
care,
Yeah. Well, gender affirming care. I have to say, Mendocino Coast Clinic does a better job at that.
Okay.
But
You
they
know-
just hired a new person at the clinic as well.
At
Who
the
is specific at Adventist
Right.
Health, who's specifically there for trans and, well, for the LGBTQ community.
correct.
Yeah.
So
Or
I think
she's actually helping the patient load with one provider, but then after she kind of does whatever, like eases that schedule load, that is her specific purpose.
Mhm.
That's great.
So there's an openness to that.
Mm-hmm.
So the question of I forget what it's called, the death with dignity.
I think is the California term, yeah.
So our hospice is with Adventist Health. They're not in with death with dignity. They will make a referral, as they will with someone wants a surgical abortion that's elective. They will make a referral.
Oh, they will,
Okay,
Good.
so that's where it is. The same thing with death with dignity. They will make the referral.
What
So-
does that mean? What do they refer you to?
Well, so the policy is, and I'm not necessarily in agreement with this, but this is what the policy is that, say, if someone's at hospice and they want to do death with dignity, hospice can't be involved. So what we would do is get the primary physician involved. And you need, I think, 2 doctors to sign off on it. And that's usually not too difficult. There's enough doctors.
And they're Adventist doctors, or they're not?
Well, let's say,
Adventist doctors? Can they
so-
be Adventist doctors?
So, in some ways, there aren't Adventist doctors. I am not paid by Adventist Health. Okay? I'm not an Adventist doctor. I work within the Adventist healthcare system. This has to do with state law, for example, that hospitals can't hire doctors. They get around it by like having a foundation or some other way. So the hospital is, there's like 2 columns. One is the administrative column, which we're all more familiar with, you know, the president, the CEO, and the chief nurse, and all the nurses. Then there's the medical staff, which is separate. The medical staff is separate from Adventist Health. And that's my role, or my column, in that I am the chief of staff.
And who funds you?
Who funds us? Well, if you apply for medical privileges at our hospital, you have to pay a certain amount of money. I forget what it is. Like
I'm sorry, Robin. If who applies for medical?
a doctor. If a doctor wants privileges at Adventist Health,
They
Mendocino
have
Coast,
to pay Adventist?
it's like, I don't know, $400 or something like that. So we have money.
Okay.
I mean, I don't get paid a lot to do this.
But I'm just wondering who pays you, if Adventist doesn't pay you?
Oh, well, so what happens is, like when I worked in the emergency room, Adventist Health is contracted to Redwood Pacific Medical Group, which covers the ER at Ukiah, Willits, and Mendocino Coast. I would get paid through them.
It's a little confusing, so.
Yeah, it is.
So in my case, I'm starting with a brand new doctor who is at Adventist.
Okay.
So say someday I am in a position where I want to, not live anymore and do the death with dignity because I have
Mhm.
chronic disease. So could my doctor who works at, will be my physician, is she?
Yes, she can.
Could. Okay,
She
so,
can.
So it's
But we're not
like-
raising the red flag,
Okay.
but it's happening. It has happened. It will happen.
It's a personal choice of the doctors, and there's a
Okay.
few doctors, I think, correct me if I'm wrong, but my experience is there's a few doctors who also work for the Adventist system who are providing this medication also, or prescribing this medication for their patients and working with them on what that means.
Yeah.
And we will not let anybody be alone. I mean, if I have to, my commitment is I will go as just a person to be there, if they wish, so they don't have to be alone. So it's a workaround.
Yeah.
It's
Thank
a
you.
workaround. And I think I'm,
But it's a workaround that's not, well, maybe I'm wrong in this, but it's a workaround that's not forbidden by Adventists. It's not, the policy is that they won't prescribe it, but there's no particular hiding from the Adventist system if you're a doctor that does this.
right,
Yeah.
right.
I haven't seen a lot of like secretiveness about it, but maybe I'm wrong. Maybe I'm just standing in a different position where I know.
Maybe I'm being too secretive about it, but
Yeah, no,
I know it's happening.
I will leave it at that because
Yeah.
I could be wrong.
So I think patients are being taken care of what their wishes and what their needs are. It may not be always convenient. If you do want an elective surgical abortion, you are going to have to go to Santa Rosa.
My only solace is that was the case before.
It was the case
Right.
before. That's true.
That's what I convinced myself.
Essentially, it's a no change.
Yeah.
Right.
Is hospice a part of Adventist or not?
Yes, it is. Currently, it's not part of Mendocino Coast. It's part of Willits because they already have the license, and so what they just did is sort of expand the geographical territory.
What we're hoping is, and this is a hopeful sign in terms of the finances of the hospital as well, is that, and we've got a lot of unused space at the hospital currently, and then you go onto the facility. There's storage everywhere. We're hoping that they're able to put together a skilled nursing facility inside the current structure. And our understanding from that is from talking with the Adventist regional people is that would generate, that would reduce the cost of the hospital, or they would capture an additional revenue, however you want to look at it, about $3.7 million a year. That's their projection at least. And they believe currently that they're losing about $5 million. So they're almost there right there. We're also very much aware, because we've heard about this in terms of, apocryphal stories that come to us, but we've also seen it objectively in the data that Adventist has been very bad about billing and collecting.
They sure are.
They're way behind on that, and that has a great deal to do with the profitability of the hospital. That's the business side that they need to pay more attention to. Now we understand that they are working pretty hard on that as a fix, so that's good. The hospital will never make a lot of money, at least from the history I've seen and what I understand. Maybe I'm wrong, but I don't think it's ever going to be a real big profit center. But the hospital, if it's well managed, will not only meet its costs, but will produce some revenue. Okay, and so we also have to be committed to getting there, and I think we can in the near future. I think it's very possible. I'm looking forward to that. There's certainly enough volume. It's right now, I guess, an $85 million annual operation. That's
Something like that, yeah.
So it's.
You mean that's how much it costs to operate?
Mm-hmm. Yeah.
Annually?
Yeah. 2 points just to add on to that. I'm also part of the community board. There's two boards. There's a district board, which owns the hospital, and then there's the Adventist board. Okay? So it's a partnership. So I'm part of the Adventist board. And we met yesterday, and we meet with our CFO, who is very open, transparent, and really cares about the clinical care. It appears that right now we're breaking even to making a little bit of money. So I'm actually very optimistic. And we have a person who's coming in just to look at the revenue side. And her name is Becky Ryan, and she, maybe you know Becky
I know
from...
Becky Ryan.
So, go Becky. She's good. I think she's going to really enhance our revenue. So I'm really feeling optimistic. Well, I agree with Paul. We'll never be a big money maker. But what we want to do is make some money so we can reinvest in the hospital. We need a new MRI machine, $3 million. We need a new CT scanner, $2 million. And we can go on and on and on. This stuff's expensive, but that's where we want to put that profit into.
We also know that medicine is a very strong trend, and I'm just reading this and learning as I'm on the job. Since I've been elected to this board, I think I've learned more than I did in my master's program. Okay.
Not surprising.
Yeah.
It's been one thing after another revelation. But I think that now I've lost my train of thought. I apologize.
Can I just ask you a quick question? That, I actually was away for a month. I took a leave of absence, but I don't think a lot. I just went back, but the census has been pretty much the same, and I know that we suffer. In one way, I feel like there's been this misdirected, guided, or drive towards raising the census when we can't always do that. That's what our kind of rural community, we can't depend on a high census. Although there's certainly things we can do to change that, like have specialists and more be able to handle higher acuity. But I haven't seen the census change recently, so what accounts for our ability to possibly break even right now? Is that greater fiscal control?
I'm sure that Robin can tell you more, but the point I was going to make is that everything is shifting to outpatient now in medicine. That was where I was going to go. Finally recovered. One of the things that we're trying to get Adventist to do, and hopefully they'll partner with us, is we want to buy the clinic that's across. Now that used to be owned by the district, but they sold it. The building, not the land, just the building. We want to buy that back because one thing is I'm concerned about someone coming in and competing against Adventist, and we don't want that because there's not enough business to do that, clearly. But also we think it'd be a good move because that facility is going to probably have to be upgraded and expanded in the near future to accommodate the change in outpatient. And it'd be a whole lot easier if it was owned by the district than it was by some private partner. So that was the point I was going to make. Excuse me.
Well, that's good.
Yeah.
Okay. Sometimes I have train of thought issues too. So, to your question about profitability, a lot of it has to do with, in the weeds. And I've already said this is not economics 101. I think we all kind of get that. So like for oncology, some of the drugs, might cost $5,000 for a single drug treatment, and we get reimbursed $2,000. I mean, that's crazy. But if it could be acquired through the pharmacy at Willits, which is owned by Adventist, we might get $4,000 back. So we're looking at weed stuff.
A whole bunch of different
little things, but particularly in oncology.
I was told, I'm an oncology patient.
Okay.
I was told that it has to do, some of it, with the reimbursement rate that Medicare gives to critical access rural hospitals as opposed to urban hospitals. And so
Correct.
My oncologist has explained to me that, it costs Adventist more to give me a shot here than it would if I went over to Ukiah.
Yeah.
Yes. And what we're trying to do is work around, have the drug come from Willits so we can give it to you here. I mean, it's a goofy business.
It is really strange. In the old days, the reimbursement rates are based upon the old model, where it used to be cost less to deliver healthcare in a rural environment, and it did because in those days you didn't have the kinds of equipment that Robin was talking about. You didn't have to have an MRI. You didn't have to have a CT. You didn't have to have this or that, and those things weren't around. So. Okay, so, but now that you have them, and now that's modern medicine, and who would want to go back to not having them? I mean, that would kind of be crazy. But you got to understand that you don't have the flow of clients to support that. So if you make a $3 million investment in a piece of equipment at our hospital, the return on that investment is going to take a much longer period of time than if you did it in an urban hospital. At the same time, that urban hospital is getting reimbursed for those services at a higher rate than we are. So until government kind of catches up with the fact that it's harder, it costs more to deliver services in a rural area than it does in an urban area, we're never going to get around this problem. I'm glad to see that there's a lot of inventive kinds of strategies I'm hearing about. This is really kind of wonderful. It's very encouraging. Because why are we get stuck? We're a critical access hospital, we're a frontier hospital, we're a rural hospital. We got all these little designations, and all that means is we don't get as much money as other people. That doesn't make any sense.
So how do you change that? Where is that decision made?
It's a problem across the country.
No, I know,
Yeah.
but then how does that get changed?
Well,
I mean,
you
is
have a responsive Congress.
Well, that's what I'm asking. I mean, is it a congressional decision? Is it an executive function? Or?
It's primarily a legislative thing that needs to be fixed. It's unfortunately change is glacial, I guess is probably the best way to describe it. It's really hard to pull that apart. There's so many special interests and there's so much conflict. And frankly, I'm not encouraged about what's going to be in the future. One of the things that's ironic to me as an observer is Trump has this really strong support in rural areas. But if you look at during his administration, how many hospitals in rural areas closed? I mean, it's astounding. I think like 250 or something like that. It was amazing how many.
Yeah. So,
yeah. So,
I mean, the financial side to medicine is clearly broken. If half the hospitals are losing money. So I've told you that Medicare does not pay for the cost of care. But yet, for Big Pharma, they will pay whatever price they want. If you go out shopping for tires, you might get a bid and go with the best bid. That's what they do in Canada. So like, for example, these heartburn medications called proton pump inhibitors, Protonic, Somiprazole, those kinds of things. In Canada, they'll say, okay, they're all equivalent. There's 5 of them. You 5 guys give us your best price and we'll go with 1. So they get competitive pricing. Not here. So we really are at the beckon of Big Pharma. Now, the Biden... Well, we'll get to those guys.
Sorry.
You bet. Yeah. That's the double tandem. So, Biden started to change that. He said, okay, we're going to start with 10 drugs, and we'll go with that. Insulin was also an issue. And, of course, there's a lot of court challenges to that. I suspect that will go away in the next administration. We'll see. And then insurance companies. For example, United Health Insurance was one of the companies that the hospital does business with. So when the contract came up for renewal, they wanted to give Adventist Health 0.1% increase. They raised their rates 10%. We're going to give you 0.1%. Okay? All right? They made over $30 billion in profit. So it makes our system very inefficient because Medicare, which is the government, which we don't think is very efficient generally, that's our general view of government, they can bill an 8 cents on the dollar. Okay? That means $100 of health care, $8 is for billing. Okay? Well, for private insurance, it's 3 to 4 times that. They're 3 to 4 more times inefficient at billing than the government. Okay? So if we Adventist Health sends a bill to United Health, it's an automatic denial. Automatic denial. So then we have to go fight with them. Whereas Medicare will pay you in 30 days. At least they pay you, and you don't have to fight. I mean, that's ridiculous. They're too powerful. Big pharma and insurance companies are too powerful. Let's talk about the Affordable Care Act. I'm going to continue.
No, go
Sorry,
ahead, please.
I'm on my soapbox now.
Please.
You got me going.
I'm learning.
All right. So, in order to expand Medicaid, it gave insurance companies, you're welcome. Thank you for coming, 30% more than they would give, say, our hospital. So they gave an incentive, if you will, a bonus of 30% more. So under Obamacare, the Affordable Care Act, the stock prices of these insurance companies that went into that rose 5 times. Okay? So, very powerful interests. So I don't know how to change that, particularly with Citizens United, where campaign money is free speech. So I hate to be a downer on that, but that's how I see it. That's the reality.
I do think it's eventually going to have to be like federal overhaul to a universal healthcare system or something. Some model. There's all different kinds of models, but some model that takes insurance out of the.
If we could have just had a little toe in the pie of a public option, which would be cheaper, I'm saying probably like 20% cheaper than private insurance, people would gradually go to that. We could eventually grow out of that. But the moment somebody said, boo, Obama, well, we can't do it. I mean, he didn't fight for it. No one's fighting for that option, politically. I should say something positive.
Well, I mean, it is what it is.
It is what it is.
If we're going to say positive, I believe very much that we have an excellent hospital in this community. I think the medical services are very good. And we intend to work really hard with Adventist in the future to engage with this community and develop a stronger sense of ownership and reverse some of the leakage, the significant leakage that's happening with people, mostly private payers, who have private insurance leaving the county because they don't believe they can get services that they need here. We want to change that. And I think we can. And I think the future of the hospital is actually pretty good. And we'll finally see, but I'm committed to doing that work. And I think as a community, we can do it together.
I'm definitely feeling more positive about our hospital now than ever. And we're clearly going to make it. And one of the things I'd like to see, like what Paul talked about, is greater engagement with the community. You can see that commitment here tonight, even if it's only 10 people.
Yes.
That's important. So if there's a problem, please let us know. I mean, I've been trying to invite the community to, rather than go on social media, call us, tell us what we're not doing well. You know, we need your input. It helps me too.
Yeah, and please, let's keep our facts straight, because one of the things I keep hearing is Adventist came in and got rid of OBGYN. That decision was made long before Adventist was here. And it's those kinds of things that are a little frustrating. Let's make sure at least the narrative is correct. Whether that was a good decision or a bad decision, and people can fight over it all they want, but it was made before Adventist got here, so let's not stick it on them.
That's true.
Thank you. Shall we wind the formal part of this up at least?
Yeah, well, stick around. Any questions? Or
we are
you got
very
my
lucky
ear?
to have both of you. I really want to say that, and I thank you both for what you do professionally and also what you both do for the community. It's really an incredible gift.
And our staff is very committed. I mean, we have people like Rebecca, and she's not alone.
No.
You know, I couldn't ask for a more dedicated staff. They really do care.
And honestly, I mean, I feel the pinch of all these problems, just the whole national scene is like terrible financially with health insurance and our fragmented, all these things. And then we have our particular financial and demographic issues here, and all the transitions that we've been through. But I really do feel in a good position, and then recently, not to overshare, but I've been dealing with, my mother's been in a hospital in Ohio, and every freaking specialist in the world, and you can't talk to them, you can't get through the menu, you can't figure out when someone's gonna be discharged, you can't make a care plan, you can't, it's no, and my sister lives in LA and runs a school district. She can't hire a speech therapist to save her life. Like what we're definitely in a crisis in a lot of places.
Mm-hmm.
And so then when I'm here at this hospital and I see the social commitment to our community, I really feel like it puts us in a strong position.
Mm-hmm.
Because I do feel like I'm part of a team, not all the time, and I want to encourage consistent behavior, and I keep working on the clinical pieces, but I do feel like there's a really intense commitment to succeeding for caring for our community, and I don't see that currently where my mother was just hospitalized,
Yeah, I had an interesting experience with my wife's second hip replacement. Roar, who was a really was a great guy. I mean, he helped me with one of my knees. He did the first one, and that went really well. It was great. It was a very good experience. He'd left, so we had to go down to Stanford to get the second hip replacement done. At that point, couldn't get into Howard Memorial. It was taking forever. And my wife's hip was at a point where, and almost at any minute, she could take a step and the whole structure would break. So it wasn't something we could put off. So we did the trek down to Stanford, and we got a guy who was supposed to be this great expert and all of that. And he does these the hip replacements, like, I don't know, so many a week. And I tell you, he's one of the most arrogant people I've ever met in my life. And you can ask him any questions, and he did. Every time he answered a question, he smiled. He had this kind of weird smile on his face. I'm going, what the hell's the matter with this guy? And so then she goes in and has the operation, and I'm sitting there in the waiting room, and they tell me she's out, and I'm waiting for the physician. I sit for an hour and 45 minutes. I sit there waiting for someone to come out and tell me what happened. I mean, they told me it was done, but they didn't tell me what happened. So he comes out and says, "Oh, it all went well, just normal." And I said, well, wait a minute, can I ask a question? He said, "Oh, it went well, normal." Turned around and ran around, walked out. That was it. The next day, with 24 hours, they're trying to push her out because they got someone else coming in for that bed. And I'm going, oh God, this is everybody's time. All Stanford, oh, they're wonderful. It's a factory. So be grateful. We're not getting that kind of care at our hospital.
Yeah.
Anyway.
Good. Well, thank you all.
Thank you
This
so much.
is what we need, this engagement with the community.
I appreciate the invitation very much, and at any time, if you want to learn more, call me. I'll be happy to come and speak and talk at any time. Share with you what I can. I work for you. Okay, I don't work for Adventist. Okay.
Thank
Okay.
you. Thank you so much.
Thanks, Will. Good to see you.
You're welcome.
I'm glad I never got to see you.